So there are multiple studies done which to increase the frataxin expression. The human and butyric acid actually study was done in the cellular and the mouse model, and it shows that it increased expression of frataxin in cells, but the human trial has not been done yet. Resveratrol study, resveratrol is basically a natural antioxidant and anti-inflammatory agent, and for some reason it caused increased expression of frataxin. And the cellular study or mouse model showed that it increased frataxin level in WBC in cells, but the human trial, which was open label study, they include 24 patients and they use two doses, low and high doses, 12 weeks apart. And it shows no improvement in frataxin level, but it did improve the neurological outcome and also decrease oxidative stress in patients. Erythropoietin is also, for some reason, increased expression of frataxin, and there is an open label study which resulted in increased frataxin level and decrease in marker for oxidative stress. They did the randomized double-blinded control trial in adults, and it did not show any improvement in frataxin level, and neither it did show any improvement in neurological outcome or oxidative stress. So this study failed, but this is safe to use. I mean, there's no side effect of erythropoietin, but not for Friedreich ataxia. Histone deacetylase inhibitor, as you remember, I said that when you have increased expansion, GA expansion, it changes the configuration of DNA and it becomes sticky and cannot transcribe. And these agents actually reverse the process, and so the DNA can transcribe and make frataxin. So in mouse model, frataxin level was restored to normal in heart and CNS. So they used some compounds, like one of them was nicotinamide, and this is vitamin B3, and it was an open label study, and they used escalation, it's like escalation study over 8 weeks. They used dose from 2 grams to 8 grams, and they found that it showed sustained improvement in frataxin concentration, but it did not show any changes in the outcome measures, which were oxidative stress and also neurological outcome. But it was generally well tolerated, so we may need more randomized double-blinded control or placebo-controlled trial. Another agent which increased frataxin expression is interferon gamma 1b, and it was an open label study with 12 patients, and they used 3 doses per week for 12 weeks, and it was a pediatric study, and it shows that there was significant improvement in the Friedreich ataxia rating scale, which is a measure for the neurological outcome, but it did not show any changes in frataxin level. Again, it was open label, so we need more double-blinded placebo-controlled. The second target for therapeutic approach, as I said, was iron chelation. It's a possible approach, but generally not been, it's usually been avoided, and I'll tell you why. There were 2 compounds they used. One is desferrioxamine. It was not effective, and the problem with this compound was that it decreased mitochondrial iron, but also decreased cytosol iron. And if you remember, if you decrease cytosol iron, it can cause decreased expression of frataxin, so it kind of making things more worse. So that clinical trial was terminated. The other compound, again, is chelator, is the deferriprone, which shows promising result in open label study, and it did improve the ICAR, which is the International Cooperative Ataxia Rating Scale. These are the outcome measures they use for studies, and also improve iron accumulation in dentate nucleus. So they did the randomized multi-center double-blinded placebo-controlled trial, and they include both adults and pediatric patients, and they use 3 doses, 20, 40, 60 milligram per kilogram per day for 6 months. Primary objective was safety and tolerability. Secondary was neurological outcome measures by ICAR, FARS, and fine motor skills. And tertiary was to see the effect on cardiac function by EKG, echo, and Holter monitoring, and quality of life and EDL by questioning. The result shows that deferriprone was safe at 20 milligram per kilogram, and it may reduce disease progression in patients who have less severe disease. But the dose 40 and 60 were toxic, and there were some cases of fatal agranulocytosis, and it actually made the things worse. Like patients had more worsening of ataxia. Antioxidants as the main goal of treatment. Uh, Coenzyme Q10 is a natural antioxidant which is present in mitochondrial membrane, and it actually associated with the respiratory chain enzyme, our electron transport system, and help in the production of ATP and antioxidants. Deficiencies was associated with ataxia, and replacement with coenzyme Q10 shows improvement in ataxia. That's why they did multiple study with this compound along with vitamin E. There's a one open label trial with 10 patients, 16 to 40 years, and they treated with CoQ10 and vitamin E for 6 months, and it shows improvement in energy level, but there was no improvement in cardiac and neurological function. Another open label study with 77 patients, and they again include adult and pediatric patients, and it shows some improvement in cardiac function and energy level. So the third study to compare the low dose versus high dose along with vitamin E over 2 years found no change or no difference in the ataxia scale or neurological outcome, but they did not check the cardiac function in this study. Idabenone is a synthetic analog of coenzyme Q10, and it's been studied since 1999, and there are multiple studies. To date is like 19 studies, and I'm going to talk a few of them. So it was first approved in Japan in 1986 for the use of dementia, and is the potent antioxidants and electron carrier. So it's very potent antioxidants as comparable to CoQ10, but it has very good bioavailability. It's very well tolerable and doesn't have much side effects, only GI side effects and maybe reversible neutropenia. So low dose idabenone study with 5 milligram per kilogram, they used in 104 patients, followed up for 5 years, which is a pretty long study. It shows that some improvement in cardiac hypertrophy, but no effect in cardiac function and neurological outcome. So they did another study to compare low dose versus high dose, and it was a randomized, double-blinded, placebo-controlled trial on 48 patients, and it was a pediatric study for 6 months. They received placebo and one of the 3 doses, like low, intermediate, and high dose. And neurological outcome was measured by ICAR score, FARS, and activity of daily living. And it shows that intermediate and high dose provide neurological benefit and shows significant improvement in the outcome measures. It means that if you use high dose, it may be beneficial. But it was only for 6 months, so long term we don't know. Another study which was long-term follow-up, and it was open label prospective study for 10 children, and they had also adults, and treated with 5 to 20 milligram per kilogram for 3 to 5 years. I don't know how they distribute the doses. Neurological evaluation was evaluated by, again, ICAR score and cardiac outcome by echo. And this study showed that prevention of cardiomyopathy was seen in both pediatric and adult patients, but the neurological dysfunction was improved only in pediatric population. So if we use in early disease, then maybe idabenone is effective. So that's what this study showed. IONIA study, which is idabenone effect on neurological ICAR assessment, is a randomized double-blinded placebo-controlled study, which was done in response to Nicosia study. Nicosia study was done in National Institute of Health, and they actually used, again, the similar 3 different doses of idabenone with placebo-controlled, and they found some improvement in patients, but again, they found some improvement in placebo-controlled patients. So to prove that, they did this study on 70 ambulatory patients, all pediatric, and again, 3 arms of treatment, and main outcome measure was with ataxia scale and activity of daily living. And the result did not show any improvement in neurological outcome in 6 months. So they did the extension study for 12 months, which was open label, and they only use high dose of like 30 to 50 milligram per kilogram. And they did see some improvement in neurological outcome. So if you use high dose, maybe it's effective. Another study was done, which is multi-center study in Europe. Many centers were involved, and it's similar to IONIA study. They use actually 3 doses of Idabenone plus placebo. And it was to confirm the positive effect of Idabenone on neurological outcome and cardiomyopathy. They did not find any significant difference. And actually, they did not publish the result yet. I actually emailed the CEO of the company, Cenfra, and he actually replied me very quickly. He said that the investigator did not publish the study, and also there is no proven efficacy of Idabenone shown by the study. So at this point, there are multiple studies, and they did meta-analysis of the last 3 studies. They found there is some improvement. So the question is, should we consider Idabenone for treatment for Friedreich's ataxia? Idabenone is safe to use, but is not approved in USA, and parents have to pay out of pocket. So if you ask me, I will recommend in patients who are in early stage of the disease, and we'll discuss, you have to discuss with parents about the outcome measures, that they have some improvement. Studies were not long-term. They were maximum like 18-month study which were done. So they accept one which is 3 to 5 years, which is low dose. So I would recommend for early disease for Idabenone, and we have been using it. I don't know if Dr. Lassi has been using it or not. You're using it? Yeah. So we both are using it. So do patients older than 18 years also get benefit from intermediate or high dose Idabenone? The study showed that the younger the patient have better results, and even it's not very significant. So I won't recommend for adults because it didn't show much significant results. Does the effect of Idabenone depend on the disease state? Yeah, it did show that early stage, and if they have low ICARS score before the treatment, they have better or some benefit from this medication. Does pre-symptomatic treatment of genetically identified at-risk subjects delay or prevent disease onset? There's no study in pre-symptomatic patients, so they can try in future. Is there any other mechanism of Friedreich's ataxia pathology, like mitochondrial dysfunction, lipid peroxidation? We know we have tried so many medications. Seems like nothing helping, so maybe we have to look into more like basic pathophysiology. And Dr. Bellin is not here. He's supposed to be here today, and he's going to give a talk next week on basic pathophysiology and his research on neurodegenerative condition, including Friedreich's ataxia. So we will have probably more answers next week. So I will conclude my talk by saying that there is no cure for Friedreich's ataxia. Idabenone is the only treatment available. If you have to treat, use the high dose, which is 45 milligram. Like you can range from 30 to 50 milligram per kilogram, but I usually use 45 milligram per kilogram. Future studies, we need more studies with the selection of the target population, dose level, safety monitoring, and outcome measures. We also need some studies which shows the progression of Friedreich's ataxia, and there is a study going on. It's called EFACTS, which is a multi-center study in Europe, and it's basically a prospective observational study to look for natural history of Friedreich's ataxia, and maybe we will have more kind of identify participants from that study, and maybe have more sensitive and reliable outcome measures for future studies. So we need more basic research to look for other possible pathophysiology for future target treatment. So post-test, can we do it? Question number 1, genetic mutation inferred involves which gene? Ataxia, very good. Friedreich's ataxia, there is a defect in the mechanism of copper, iron, manganese, calcium. Iron.